Respiratory pharmacology. So I'm not going to do a whole lot of slides on my own on this. I'm going to use a number of YouTube slides. Mostly we've talked a lot already about infections. I will talk a little bit about pneumonia in the next slide set. But mostly we're going to talk about asthma and COPD. We're going to use supplements from commercial and other slide sets that have been produced, and we'll process a fair amount in class. So basically, oxygen is good. When someone is not breathing, it's very unpleasant, and so we have to keep the oxygen levels adequate for both length of life and quality of life. So quick case here. So Kim is a 16-year-old girl. She gets wheezy when she goes to her grandmother's camp, making you think, geez, is there something there that she might be allergic to? Is this an allergic-mediated asthma? She's also wheezy after soccer practice, making us wonder if this is an exercise-induced bronchospasm. We used to refer to that as exercise-induced asthma, but we're really getting away from that term. She's been diagnosed with asthma, and she uses an albuterol inhaler. And so your challenge is to try to decide, is that adequate for her, or does she need an everyday inhaler? What should you do? So in asthma, there's a number of different things that are going on. We call it a reactive airway disease because the bronchi spasm, they constrict. There can be inflammation there can be swelling there, and there can be excess mucus there. What can trigger that asthma? Aspirin can in a number of people, and so if they're aspirin sensitive, they need to be very careful to avoid aspirin. The rest of the NSAIDs less likely to do it, but some people are sensitive to the other NSAIDs. Allergens, this time of year, which it's now September, National Ragweed Day is August 1st. Anytime after that, you're going to have people that are going to have flare-ups of their asthma and other allergy-related symptoms such as sinus infections. Cold weather can cause an asthma attack. Sulfites, especially important because they're in wine, they're in various salad bars, they're in a lot of different places in the environment. Beta blockers don't exactly trigger asthma, but they'll make it more of a problem if it is triggered because they basically have stopped that bronchodilation that one gets with beta stimulation. So we need to be very careful with beta blockers with anybody with asthma, COPD, or any chronic respiratory illness. So what happens? So what are we going to try to do? So for Kim, we want to open up her bronchi. We're going to use a short-acting beta agonist, such as the albuterol. We're going to try to decide whether that's active using peak flow measurements, which you'll learn about as you get to asthma diagnosis and treatment. Another way you could open up the bronchi was instead of pulling them open with the beta agonist, you actually could stop them from constricting. And constricting is usually a parasympathetic function, usually the muscarinic receptors. And so if we block those, we basically will stop the constriction, and the net effect is the equivalent of a dilatation. We can also try to stop some of the inflammation from allergic neurotransmitters. Histamines obviously can do that. Leukotriene also does that. And so there's a number of different medications we can use that will block histamine and block leukotrienes. We can also try to decrease the inflammation overall. Steroids will do that. We can use inhaled steroids or we can use oral steroids. Mast cells are also a mediator of inflammation, and we can block those using cromolyn, although the only real cromolyn product that's available now is really more intended for nasal issues. So what's the difference between a short-acting beta agonist and a long-acting beta agonist? The short-acting beta agonist is supposed to start working right off and only work for a few hours. The long-acting beta agonist is supposed to give you anywhere from 12 to 24 hours of effect. Often we'll combine those long-acting beta agonists with anticholinergics. We call them long-acting muscarinic antagonists, so we'll often refer to them as LAMAs, L-A-M-A, and so you'll have some combination inhalers that are LABA LAMAs. the biggest thing that you have to be aware of is that when a LABA is used alone, there were a few studies a number of years ago that suggested that the increase of death rates went up in people with asthma when they used just the LAMA. I'm sorry, just a LABA. So we rarely use those alone now. Almost always the LABA is used in combination with an inhaled corticosteroid because the data does not suggest that that results in an increased risk of death. So you'll rarely see the LABAs used alone. There's a lot of studies that are trying to figure out whether or not that relationship is real, and there is a feeling that we can probably go back to using LABAs. You can use them in COPD because there's been no association there, but with asthma we tend to avoid them. Spacers, a lot of people are militant. Oh, you got to have a spacer. The problem is that research has never really supported the use of spacers. Insurance will look at that, of course, and the study they usually cite is the Dolovich study. And they basically will say there's no hard evidence that spacers are helpful. We will not pay for them. A lot of clinicians believe they are more helpful. It is one of those things that you can actually make a spacer out of a Coke bottle if you really want to. The other thing is that if people are using their inhalers correctly, there may not be a benefit of spacers, even though I know some of you have been taught that they're essential. Spacers can also be called valved holding chambers. So the expert panel guidelines, these are referred to as EPR3. These are guidelines that you'll probably want to look up and actually have a copy with you in your early stages of your career. Most of us in primary care are really in the steps 1 through 4. Step 5 is some primary care people will stay with that, but most folks will usually refer them to pulmonology or alternatively allergy if they get to that point. So step 1 is you got somebody with asthma, they use an intermittent short-acting beta agonist. As long as they're not using it more than a couple of times a week, it's fine to just stay with that. Step 2, you'll add a low-dose inhaled corticosteroid. Alternatives would be cromolyn, which again, it's only available nasally. A leukotriene inhibitor, which if you've got somebody that can't use inhalers like a child, then some Singulair, which is a leukotriene blocker, is a great alternative. Nidocromil is another medicine that can be used. We'll talk about it in a second. Theophylline is used rarely just because it has such a narrow therapeutic window. The difference between the therapeutic dose and the toxic dose are just too close together for a lot of people. We'll talk about the other medicines as we go on. So the leukotriene receptor inhibitors or receptor antagonists coming down in cost. Still not cheap, but they're available in generic now. They should be taken at bedtime. The most common one is Singulair or Montelukast. The Accolate, which was the Zafircolast, was the first one out. It was associated with some liver problems, and Singulair does not seem to be associated with those, so it's pretty much taken over the market. We talked about cromolyn, which is now only available as a nasal. Nidocromil, which is Tylade, was another mast cell inhibitor, and it really is not available here in the United States, although it is still listed on the GOLD guidelines because it is available in some other countries, and also in the EPR3 guidelines. Asthma, lesser used meds as noticed, theophylline. Theophylline is a non-selective PDE inhibitor. It's going to have a lot of the same effects that the other PDE inhibitors are going to have. May actually have some benefit as far as erections, since sildenafil is a PDE5 blocker. Also may have some skin benefits. Again, the problem is that by the time you get a dose to a therapeutic level, the concern is that people will become toxic. When they become toxic, they're really sick to their stomach, they're throwing up. It's pretty unpleasant for them. Zolatan or Zyflow is another sort of a variation on a leukotriene inhibitor. It's a lot more expensive. Usually I only see the pulmonologists use this. I don't really see a role for it in primary care. Now, you'll notice these two medicines both end in MAB. MAB medicines are monoclonal antibody medicines. And these are sort of the medicines of the day, if you will. These are the medicines that everybody are very excited about. These are medicines that attack one or another processes within the body and will neutralize that process and result in decreased symptoms there. So we have monoclonal antibodies that attack the substances that are responsible for Crohn's, for rheumatoid arthritis, for psoriatic arthritis, for psoriasis. And basically there's two that are specifically designed more for respiratory type issues. Xolair is an anti-IgE. IgE is the immunoglobulin that's involved in allergies. And it's very expensive, but for some patients, especially if they have particularly high IgE levels, then they will benefit. And most folks, again, would probably be treated by a pulmonologist. Nucala is an interleukin-5 antagonist. And it also will lower eosinophils. And if you have somebody that has a high EO count, this may be an option. I can't even find the cost on this. Previous times I've looked at it, it's been at least $1,000 a month. Again, not something that I would jump to immediately, but be aware that specialists might use it. Now the gold talks are going to be on YouTube. I'm going to use some of the ones that other folks have done. We'll see how that works. I may do one myself next year, but I do think that the folks that have done them, especially the one that's done for the pharmacist students, is pretty well done. I'd be interested to hear your feedback. The GOLD guidelines, emphasis diagnostic criteria. They look at use of pulmonary function tests. They now are looking more at symptom reports in regards to classification as well for the ABCD symptom classification. So listen carefully to those, and especially if you're going to be taking care of a lot of patients with COPD. COPD, very common. Lots of people have it. Major cause of disability. Big thing is smoking, of course. Air pollution does contribute to it, and there is a genetic component in some people. We'll talk about that genetic component in a minute. Really, COPD is two diseases, chronic bronchitis and emphysema. Some people throw asthma in there, although that's usually not included anymore. Chronic bronchitis is from smoking damage, inflammation. They get a lot of mucus. Emphysema is more air trapping. They don't usually have quite so much mucus. It's unusual for somebody not to have elements of both, although some people will be predominantly one or the other. Chronic bronchitis, you got to have your cough for 3 months in a row, at least 2 years in a row. Those folks have decreased ciliary function. Which is important because when they stop smoking, when the cilia start functioning again, they almost will cough more just because it's kind of trying to lift all the black stuff and disgusting stuff that's deep down in the lungs. So you have to warn these people that when they stop smoking, they may feel worse for a little while before they feel better. Most people with chronic bronchitis have adventitious sounds. What I would call coarse crackles, what some of you would call rhonchi. I actually don't ever use the term rales or rhonchi based on a Lancet article from a number of years ago, but I know that they have crept back into the lexicon. So emphysema is loss of alveolar walls and loss of elastin. You can see the people that have a lot of that because they have a lot of wrinkles on their face. These folks basically have air trapping. People that have alpha-1 antitrypsin deficiency get this predominantly. They think that there's probably, tens of thousands of people in the United States that have alpha-1 antitrypsin deficiency. The prolastin people will provide testing for nothing. You can easily get a alpha-1 antitrypsin test for nothing. If you go online, there's actually a couple of other places that will provide them. The drug companies that make the alpha-1 antitrypsin drugs, because they are at least a couple of $1,000s a week, can clearly afford to do case finding, and they hope that they find people. Now, there are a lot of people who are heterozygous for this. So if you have a ZZ report, you have alpha-1 antitrypsin. If you have MM, you're all clear. The people that are MZ, MS, some of the other variants might actually be a little bit more sensitive to infections and sensitive to the effect of smoking. And the folks that do the testing say that this is a real benefit. If you have somebody that's MZ, then you probably are going to have a little bit more ammunition, if you will, to try to get them to stop smoking. So people with emphysema, thin, barrel chest, distant breath sounds, all the things that you've already learned. And the treatment for emphysema, predominantly a LAMA. Again, there's two types of receptors for the parasympathetic nervous system, the muscarinic and the nicotinic. These are the muscarinic receptors, and they will cause opening up because you're blocking those muscarinic, those constricting receptors. You can also use, antibiotics on a regular basis. We try to avoid antibiotics in most people. People with COPD, the standard is to go ahead and put them on antibiotics whenever they have even mild infections, just because the morbidity and mortality is so high if you don't. That may change over time, but if you have somebody that has COPD, the general standard is to treat them. Steroids, inhaled and oral, are useful, and you can also use other bronchodilators such as a LABA. There is, various levels of treatment, and the Trelegy inhaler, which has all three inhaled corticosteroid, LAMA and LABA, is now being used more. Whether it really improves outcomes beyond a LAMA-LABA, I don't think is proven yet. So I'll do a second short talk with a little bit on smoking cessation and a little bit on pneumonia, and the others, as noted, will be other YouTube talks.